So we have kept the best for the last. Dr. Suvira is going to talk to us about premium IOLs and what to do and what not to do.
So with the interest of time, let's just get right down to what I'd like to share with you is me as a refractive cataract surgeon, how can we try and minimize the litigations that come to us in our premium cataract practice. I mean, cataract has changed completely. It's no longer a surgery where you just remove the cataract, put in a lens, and you want to make the patient see better. It's now a refractive cataract surgical experience. The IOLs are virtually planned and customized to meet the patient needs and expectations. So I think what we need to remember, one thing is that if a patient comes and complains to you following cataract surgery, it means he's had a suboptimal visual outcome, which means you've not met his expectations, which means either you've not explained to him all the things that can happen and what he should expect, or you've not taken time to emphasize what are all the limitations, merits, demerits of all the premium IOLs. So in order to be able to meet the patient expectations, it stands on 4 great pillars. 1, the thoroughness of workup, which I think is the most important. 2nd, the detailed counseling. Of course, you need surgery to be pristine and uneventful, and optimal postoperative care. Now, with respect to preoperative workup, we take our history, but make sure you rule out things like, is there amblyopia? Is there any old history of trauma? Is there any systemic medication like for tuberculosis? Could there be any family history of any other conditions? All these are subtle, but with a significant potential of reducing the post-op vision. So don't discount taking all these interesting histories. Now, when we come to clinical examination, we all know we got to take care that we not only look at the cornea and the cataract, but make sure that the adnexa is infection-free. And finally, when you examine both the eyes and adnexa, following that, remember that you're not God. You don't know what the retina surgeons know better. So often in practice, we hesitate from taking opinions. I think it's extremely important not to hesitate to take opinions from the specialists in the other field, not only because it will save you, but because it is the right thing to do. They know much better about that particular aspect of the eye, and therefore you must take their opinion. When in doubt, you investigate. When in doubt, you always do a little extra rather than less, because you want to rule out any other kind of comorbidity which may have a negative influence on the end result, despite how well you might have operated. Coming to premium IOLs, remember that it's very important to achieve accuracy in data acquisition, because finally, if they don't see clearly, they're going to want to blame you, because they're paying to see for distance and they're paying to see for near, right? So accuracy of data acquisition is very important. How you do your keratometry on whatever instruments you're used to, whether it is the keratometry or the IOL power calculation, make sure you take at least 2 readings on 2 different instruments that measure differently. And finally, out of the 3 readings that you take, look for a concordance in at least 2. That's Warren Hill's triangle of agreement. When you find that there is a similarity, it's very close for at least 2 of them, that's the reading you take for your IOL power calculation. With respect to IOL power calculation, optical biometry is the gold standard, but what we do in our institute is, should you have a discrepancy in the axial length of 2 eyes of more than 0.2 or 0.3 millimeters, repeat your optical biometry. And when you're dealing with the outliers, like patient is unhappy with the first eye, and he's got a silicone oil-filled eye, or extremes of axial length, I would consider outsourcing it to get an optical biometry done from another institute. We have Deepak Bhatt here, so we get the IOL Master 700, and having done that, then we compare everything together, and then we decide which lens to put in. Many of the 3rd generation formulae, like Hoffe-Q, is still the gold standard, which we do use for extremely short eyes, but a 4th generation formula, which is the Barrett Universal 2, can be taken as something you can always trust. We have the Lens Star in the institute, so we also use the Hill RBF, because that's a good, it's an artificial intelligence-based formula which doesn't rely on the effective lens position. Post-refractive surgery is again a bit of a problem. You get these fussy patients who are now come to you for a cataract, and since in a refractive surgery patient, he's already had his refractive surgery done, the dynamics of his cornea have changed. Most of the formulae are based on looking at the corneal curvature and the length. So it's always going to be questionable, and we need to tell patients that there is a possibility of a residual refractive error. But what we do is we get an IOL Master 700 done, because that tells you the true K. We use the formulas, which is the true KTK formulas. We go on AICRS online, and with and a Haggis L as well. We take 3 different sets of readings and then decide because everything in premium cataract surgery rests on what is the lens that you're going to put in. By the time we get to becoming fairly good surgeons, surgery is not the problem. It's the workup and it's the decision making as to what is best for the patients. Toric IOLs, again, I always discuss with the company people, and I also double check it on a Barrett calculator. I cannot emphasize less about the importance of ray tracing abrometry. Any other abrometer will do. When patient comes to you for a premium cataract surgery, you first need to know that the rest of his eye is normal. The retina colleagues, they will very happily do a macular OCT, and we know that the macula is okay. But how do we tell that none of the symptoms are caused because of the cornea itself? So I like to do this ray tracing abrometry, at least in all our premium IOL cases, so that we want to make sure that the cornea is not the cause for the symptoms. Coming to counseling, a lot has already been discussed. Video counseling is, I think it's a good idea. We've not started it, but I think it's useful because everything that has been discussed is now documented. How much chair time? It takes a lot of time to understand patient expectations and to explain to him about all the different IOLs. Then again, who should do it? Personally, I think it should be the surgeon who does it. And if at all, like in our center, we have a counselor who does it. They come back to us when they're premium IOLs. We discuss them themselves. And if it is a counselor, I think they should be well versed with what your results are, how well this particular lens does. You need to constantly educate them as well as to what are the results in your hands. Because none of us are going to be able to speak with that level, with that confidence in our body language until we really, really do know. Make sure that all the decision makers are present. We've already spoken about speaking in simple words. I use an eye model. I find that helps a lot. Patients understand where the incision is, where the cataract is, where the vitreous is, where the retina is. In high myopes, that where's are likely to be the weaker areas. So I use an eye model always. Explain to them, unki aankhon mein ki kya halat hai, what's going on with their eyes. Understand. Now, what takes time is understanding what are their visual needs, what is their lifestyle, what is the ambient illumination. This is very important. If you come to my house, there are only dim lights. I would be very unhappy possibly with a multifocal. So even in terms of their lifestyle, you want to see where they hold, what they hold, depending on their arm length. Everything has to be taken into consideration, and that takes time. So you're going to have to be able to give that time, and personally, I think we need to give that time ourselves. Nobody else can come back and say, ma'am, this would be a good lens for this patient. It takes time for you to figure this out yourself. And I think it's very important for us to listen to what the patient is saying, to understand what his expectations are. You know, is he saying, we have a doctor who came recently to us, post-LASIK eye, I don't want glasses. I just don't want glasses for distance or near. She's post-LASIK. She's got an NS2. Her retinal acuity meter, she doesn't improve beyond 612. She's got subfoveal drusen. Now, they're going to come with these expectations. You have to be able to address these and be very clear to them कि हम कहाँ तक आपको लेके जा सकते हैं, you know. And I think equally important is this understanding when not to implant a premium IOL. We want to do it. Revenue is great. It's a great high because you're putting in a fancy lens and you think you can promise him the earth. But if I get a patient who comes to me with 10 pairs of glasses, who drives at night, who says, I'm not going to, why should it take so long? Why should photopsia take so long? That's one, the kind of very, very fussy patient. I would think twice. I would send them, say, go think about it, come back, and when you're willing to accept that this is possibly what you will get, then and only then do you go ahead with it, right? And if a patient has obviously got a lower MTF in the cornea for any reason, if he's got a cornea that's not so healthy, or if a patient, very often we think, iske liye this is the best lens. Like my mother, she said, I'm happy to wear glasses. Now, if there's a patient who comes to you who's actually happy to wear glasses, you may be happy putting in a monofocal lens, So I think, and when we come specifically to multifocal lenses, they need to understand the trade-off. I think the first thing I tell my patients in practice is the clearest vision is got to you by normal human crystalline lens. anything and everything else that we put into the eye is going to come with some element of a compromise. They need to understand that we are buying the depth of focus, but we are paying with the currency of contrast. And that we need to talk to them that the contrast loss, that is the overall drop in the overall brightness, is here to stay. That doesn't abate with time. We need to know that first. And the patients need to be aware of that before they go in for surgery. So I tell them there'd be like a 5 to 7% drop in the overall brightness, but generally most people will do well. You will always require bright light for reading. This is something you need to tell them, and then they accept it, and then they come back to you. With photic phenomena, it's a good idea to show them pictures. I mean, I may say glare, halos, double vision, starburst, but what exactly does it mean? When you show him the pictures pre-operatively, कि operation के बाद 6 महीने तक हो सकता है ये दिखेगा. When you tell them you might see these halos around lights, because once I was driving home a few months ago after changing my glasses, it was decentered, and I could suddenly see halos around light. It's disturbing. It actually is. So pictorially, if we show them what they are likely to accept, then I think it's a fairly good chance that they might be happy to consider that neuroadaptation will kick in. It can take sometimes even up to a year. But honestly speaking, more often than not, as long as they're the relaxed personality types, it's not very common that they come to me, yeah, we see a little bit, we're very happy. Because I think if you can hit their target of reading without glasses, with your brilliant biometry, and you've spoken to them about the other things that can happen, I find that they are pretty happy to, accept those few changes that are going to become better over time. Having finished your detailed counseling, give them time to process it. We've discussed this already. Suddenly you can't tell them, sign karo, kaun sa lens chahiye. Many people do that, but that's wrong. With the decision makers, let them go home, let them think about it, then let them come back to you, and having thought about it as to what they want, what is their budget, what trade-off are they willing to accept, then let them come, and only then do you take a written informed consent from the patient and the relative. There are some cases which have a guarded visual prognosis, advanced glaucoma, or some macular issue. In those patients, in the OPD itself, even before we've decided on the surgery, in our OPD paper, we write down, I have been explained in my vernacular language that I've got, say, for example, advanced glaucoma, and there is a possibility that after surgery, I will not see 100% as well, and I accept that. So normally we also have a GVP form, but usme to is just one line of what the thing is. Now we write an entire paragraph as to what exactly the issues are. He has understood it, and we get the patient and the relative to sign. Needless to say, we've got to be as careful with respect to making sure our surgery is uneventful. Intraoperatively, I would just say, let's not talk during surgery. We all forget that the patients are awake and they're all listening. And they might one day hold it against you, because when you're discussing what you did on the weekend or what has to happen on the next table, or jumping from here there to sort out issues, you're going to, it 100% shows that you're not totally focused on what they're doing there. So we have to be mindful at all times, because anything and everything we say can be held against you. And of course, we've gone through the details of documentation. Make sure that they're clearly written, they're thorough, and they're complete. Coming to the last part of my talk, do we have a couple of minutes more? Yeah. Now, that's the problem, right? He's paid for a premium IOL, he's paid you $1.25 90,000, whatever, and you put in a premium IOL, and now he's come to you and he's unhappy. And this is what we all worry about, right, after our surgery. Because even, I think one more point I'd like to add in the counseling is that I always tell the patients that at the end of the day, it's machines that do the measurements. They can see how considerate you are, they can see you've taken multiple readings, but I let them know, in fact, I tell any and every patient, all my premium IOL patients as well, that there's a good possibility that you will require glasses for 5 to 10% of your activities, both either for distance or for near or for both. I'm not saying this because I want to save myself, I'm saying this because this is the truth. I see a lot of patients who are roaming around in practice who promise no glasses at all. And I see patients who come to my clinic who are walking around with a great multifocal, but with a residual refractive error which is left uncorrected. And that patient is not happy. I had a multifocal patient, she's a doctor friend of mine. 6 part N6, brilliant, can read Gujarati N5, a homeopath. But she said, Doc, when I'm driving now, I find it slightly hazy. She, in one eye, had a minus 0.5 refractive error. I said, make these glasses, keep it on your dashboard, wear it by driving. Now, what have I done in that? I have done what I promised. I have told her that you may need glasses, and I made her comfortable for that one activity for which she required glasses. There is something called mechanical error of the machines. There is something called corneal biomechanics. And there's also a fact that each of us, Dr. Venkatesh, how many surgeries have you done? How sure are you that each and every incision is going to be exactly bang on? Is it going to have the correct length to to be astigmatically neutral? Or the biomechanics is another thing. The wound healing and the residual refractive error goes beyond what your pre-op workup is, no matter how good it may have been. So it's not even so much about over-promising. It's the fact is that they may require glasses, and I think everyone should be told that. Now, suppose he's unhappy, and he comes to you. He's going to take time. You never dismiss him casually saying, oh, you are 6'6", N6, go, you'll be okay. You have to pay attention. You have to understand his pain point. We do not dismiss. There's nothing casual, oh, it's sab theek hai. Do your best to address it immediately. You need to know, the patient needs to know as well, that you are taking his complaint seriously. If he thinks you're very casual about it, he's going to, come after you in a big bad way. And finally, as practitioners today, we need to be equipped, all of us, with the medical know-how, with the knowledge, with the ability to tackle each and every of these situations that come. And should we have limitations in that? Yeah, this is beyond me. Seek counsel. Speak to your other colleagues, speak to the other seniors, and don't say anything that can be held against you, because that happens. They will hold on to that one point that you might have said. You're saying it in a compassionate, caring way, but they will hold it against you, and they do, right? Now, suppose you've got a patient who comes to you with a residual refractive error. First thing you need to do is reassure. If it's a tiny refractive error, you know that wound healing. I have found in studies that I've done that the quality of vision improves over 2 to 3 months. Agreed, but in about three weeks, you're likely to get the refractive error to be fairly stable. You may need to talk to them about the need for little glasses, contact lenses, laser vision correction. And if it's the first eye, you can then say that, that's what I do for my multifocal premium IOL practice. I tell them beforehand that we'll see what we get with the first eye, and then I take at least 8 days before I plan the second surgery, wherein many people don't bother. Oh, you're okay, right? You can see, right? Aapko dikhta hai na, phone dikhta hai na, TV dikhta hai na. They will not check the vision. But I think it's safe, and it's very important that we look at what is the quality of vision in about day 7 or day 8. Which of the patient's visual needs are met, are left unfulfilled? If he can't see distance better, or is he seeing very closely here, but she wants to knit and she wants a little more of near. So when you address the patient's visual unmet needs after the first surgery, you're able to tackle whatever else that could have been left unfulfilled in the second eye. With photic phenomena, rule out things like dry eyes, a decentered lens, a residual cylinder, a PCO, CME. All of these can result in photic phenomena. Give them yellow glasses. They're available, and they do quite well with them. And most often, you just need to reassure them, because I yet have to see a patient with photic phenomena that did not go away with time. And so there's something called night myopia. Sometimes you might see patients say, raat ke waqt nahi dikhta. On a ray tracing aberrometry, you can pick up night myopia. And though he's 6'6" and 6 in the day, he may require slight myopic correction at night. For reduced contrast that happens, that they are not expecting or they are not understood clearly, just ensure, I tell them to change the lighting in their rooms, and they are a lot better. I think, and then finally, when there's a case against you, we've discussed all of that in detail. Make sure indemnity insurance is up to date. Make sure all your documentation is proper, and seek the correct guidance. We in Bombay, I think it's a great idea, and anywhere, I think, you should send, when you just get aware of, which they've already discussed, my panel here, that somebody looks like he's going to complain and he's not happy, get another opinion from a senior in an institute. I tell you, it saves you, because when they get somebody else saying that everything is fine, they generally ease off, and it all goes quite well.